Prior to beginning the activity, please be sure to review the faculty information and disclosure statements, as well as the learning objectives. After listening to the activity, complete the post-test by clicking the Earn Credit link in the episode description. Downloadable slides and resources are also available. The following presentation is copyrighted by Medscape. No use, broadcast, or recording of this presentation or any part thereof is permitted without the written authorization of Medscape.
The following presentation is part of a certified educational activity provided by Medscape Education and supported by an independent educational grant from Ardelyx.
Hello, and welcome everyone to tonight's program. Okay, so this is Constipation Class and IBS-C Challenge. I want to introduce myself. I'm Lynn Chang. I'm a professor of medicine at the David Geffen School of Medicine at UCLA, and I'm the moderator and a speaker today. And I also want to introduce our faculty, Baha Moshiri and Chuck Vega, and I'm going to have them each introduce themselves. Baha, you want to start?
Yeah, sure. I'm Baha Moshiri, and I'm at Wake Forest. It's Atrium Health, which is now Advocate Health. I'm the director of motility there, and I'm very excited to be here with all of you guys. Thank you for coming.
And hey everybody, I'm Chuck Vega. I am your primary care representative here tonight. I'm a professor of family medicine at the University of California, Irvine, where I'm also an assistant dean in the medical school. But most importantly, I've worked now in the same federal qualified health center for about 30 years. So really happy to do that.
Okay, so I want to first, I don't know if this... Okay, so, yeah. So this is a very special type of event called Faculty Feud, and we have two teams, and we want everyone to join one of the teams, Motility Mayhem and Colon Commandos. So if you can join. Okay, so we're going to try one question first so we all get used to this, and the question is, which state capital has the highest population?
See some devices out, that's great, get them out. This will be fun, that way you can participate and see who wins. Motility or colon?
Okay, so let's see. Okay, so we have Phoenix, 37, Austin, Columbus, and Indianapolis. Okay, so that, yeah.
I love geography, that's cool.
Okay, we are going to start with round one, diagnosis dilemma. Okay, so 100 gastroenterologists were surveyed on this question. What differentiates irritable bowel syndrome with constipation, IBS-C, from other types of constipation disorders the most? So we give you a chance to answer.
Faculty Feud implies that we are going to, which I know which position I would come in if that was the case. But no, it's actually more of a audience competition.
Okay, so 100 gastroenterologists, this is the survey results. IBS-C symptoms, 40. Pathophysiology of IBS-C, emotional burden for patients, 12. IBS-C presentations, 10. Impact on quality of life, of patients' quality of life. So we're going to go ahead and start talking about this topic. I'm going to kick it off by talking first about the worldwide prevalence of IBS. It's really common. I'm sure you all know that. This is data from a global epidemiology survey that the Rome Foundation conducted. And you can see all the different areas of the world that patients were surveyed. So about 4 to 11% of the adult population is impacted by IBS, so it's very common. These was from 24 countries, over 54,000 individuals. And if you see the breakdown by IBS bowel habit type, where the three main ones are IBS with constipation, which is IBS-C, IBS with diarrhea, IBS-D, IBS mixed bowel habits, IBS-M, and IBS unspecified. And a third of the individuals with IBS have IBS with constipation, which is the focus of tonight's educational event. So IBS pathophysiology is more complex. It's multifactorial. You can see the different factors that contribute to someone having IBS. And this is important because a lot of patients want to know, why do they have IBS? So it can be a genetic predisposition. There's also environmental factors like early life environment, food and GI infections can increase the risk for IBS. And then when you look at just the pathophysiology, there's evidence of altered immune function, altered intestinal barrier, visceral hypersensitivity, abnormal GI motility. So there's a lot of factors that play a role in having these patients with symptoms. And the pathophysiology is not always the same in every individual, but they have very similar symptoms. So this is a study that we did where we looked at pediatric and adult literature to look at the risk factors for IBS, and it's a lot of papers. And what you see on the top row is these are the risk factors in the green that increase the risk of adults and children getting IBS. So female sex is more likely to have IBS, having gastroenteritis, having trauma, abuse, stress, psychological disorders, and interestingly, non-GI conditions like poor sleep or muscle aches, somatic symptoms. And then if you just look at adults, because there's a lot more adult studies than children, you see some additional risk factors like family history of IBS, obesity, abdominal surgery as well. On the right side of the screen, and we don't have many longitudinal studies, but this is important, what factors increase the prevalence and persistence of symptoms? Why do symptoms keep persisting in patients? And what you see here is stress and psychological disorders can impact those where the symptoms don't resolve as easily as those who don't have it, as well as gastroenteritis. So right now, well, it's actually since 2016, but it's only in the last couple years that changing from the term functional gastrointestinal disorders or functional bowel disorders has changed to a new term called disorders of gut-brain interaction. And that's really trying to represent all of the scientific literature that has showed that IBS and other similar disorders like functional dyspepsia, functional chest pain, are due to an alteration of the way the gut and brain communicates. We call it altered brain-gut interactions. So now the terminology is disorders of gut-brain interaction, or DGBI. And these are a group of disorders that are classified by a number of GI symptoms that relate to any combination of the following: a motility disturbance, visceral hypersensitivity, so they feel more in the gut than normal, altered mucosal and immune function, altered gut microbiota, and altered central nervous system processing of visceral information that goes from the gut to the brain. And so these are the main themes and pathophysiologic mechanisms that underlie IBS. Now, what's interesting about IBS with constipation is that patients will have symptoms that we suspect they would have, like abdominal pain, constipation, bloating. Those are very common symptoms, as you can see here. But they also have upper gut symptoms. So we try to classify a lot of these disorders by the anatomic region we think that the symptoms are being derived. However, a lot of these patients will still have symptoms in other parts of the GI tract. So they can have heartburn, dysphagia, nausea. So it really can be a spectrum that we see in these patients. And then these symptoms, even though they are not like anatomically burdensome, it's not a stricture, it's not a tumor, but they really can be very bothersome to individuals that are affected with IBS with constipation, and it really impacts their quality of life. They have impaired or decreased quality of life. So you can see that over 50% of individuals with IBS-C will have extremely bothersome symptoms that will drive them into seeing healthcare providers, or somewhat bothersome in a third of them. So most patients are really impacted. And if you look at the healthcare costs in IBS, it's actually highest in IBS with constipation. On the left, you can see the annual healthcare utilization rates in IBS patients versus non-IBS controls. You can see how many of them will go to outpatient visits, the emergency room, have a lot of lab testing, prescriptions, and then the cost is high compared to individuals without IBS. And the interesting part, as I said, is that a lot of the IBS patients will seek healthcare for non-GI symptoms, because they can have comorbidities. So a lot of the healthcare expenditures are not just with GI symptoms, but also the non-GI symptoms. So I don't know, Baha or Chuck, do you have any comments about your experience and what you think about this?
I was just really intrigued by your discussion of the pathophys and how to discuss that with your patients, because that's really where the rubber meets the road. Now, if you have 2-hour visits, you could probably do a deep dive into that pathophys because it's extensive, right? So what I try to do is impart to my patients, and I'd love to hear how you do it, although you probably have a lot of patients who come to you with a diagnosis for many years and complications and that low quality of life. But I really emphasize the visceral hypersensitivity. I emphasize that the symptoms are real, the diagnosis is quite real, and that we have directed therapies for it. And I find that you're validating the patient's symptoms and their story, but at the same time, kind of setting up as well that you don't need a colonoscopy automatically for this. We're going to search for red flag symptoms, and we're, for those who need it, but most do not. And so trying to set expectations that we really want to get you more functional and improve symptomatology as opposed to do an extensive workup looking at, 15,000 different pathological possibilities. I think those are some of my keys from practice.
Yeah, and just to add to that, I think most of the time patients don't necessarily want an exhaustive search for other diagnoses. I think part of the problem is that, probably their clinician, whoever they were seeing, didn't really explain things in that way. And I think once you put it in that terminology, they kind of get it. And they understand that stress can worsen it and all of that. And then I think you you get rid of those implicit biases that perhaps others may have had, and you're much more able to get the patient to do the treatment that you want them to have and have compliance.
I think it's great to think of bias too, because we're going to come back to that at the end of this discussion, but this is a diagnosis that people freely make fun of. Comedians, friends, family, like it's kind of a joke, but when you have difficulty in your family life, in your work life, in your social life, it is definitely no joke. So I take it quite seriously. But I do monitor patients in terms of what they've heard and what they know, because that could be really helpful to just level set and help you understand how am I going to start this conversation as well.
Yeah, I think really, and we need to move on, but I just want to make another point is, even though we intrinsically know that physiologic changes and the function changes can lead to symptoms, in Western medicine, we really tend to think that we have to see something more anatomic or structural. And when you don't, that they're not real symptoms, but they are if you have a physiologic disturbance. So explaining that to patients is really helpful. So we're going to move to our next question that Chuck's going to take on.
All right, so which of these devices, ready? Good. Which of these key Rome-4 diagnostic criteria for IBS-C is most prominent in your treatment decision making? And they should be coming up to you now, so you can mark down which ones you think are important. But they're mostly going to be positive, as we just saw from Lynn's presentation. So abdominal pain intensity and frequency is the most common, followed by symptom onset, duration, percentage of bowel movements with the Bristol Stool Scale, 1 and 2. Same, so Bristol Stool Scale is less popular, but still used. Change in stool frequency, not as much. Okay, that's good information. So this is a study patterned on the National Health Interview Survey, looking at adults with IBS. And you can see this is, while we're focused on IBS-C, we included data for IBS-D here just to compare and contrast. I was surprised by this because what's really bothersome to my patients and what they talk about a lot is the abdominal pain, the cramping, discomfort, and it's nice to kind of quantify exactly what they're feeling, so I try to have them become a little bit more descriptive. That might actually help me target therapy, but it was both abdominal discomfort and abdominal pain here with at least a moderate amount of severity, and almost half of folks experience those symptoms all or most of the time. So this is why it's so debilitating. That was a study over the past 7 days. They also looked at treatment patterns and were patients satisfied. So this is a big deal. This is a hard thing. And as was discussed, lots of other disorders going on. So this could be folks who have PTSD or generalized anxiety or other mood disorders. And so this affects their perception of the interaction. So we really want to keep those things in mind and treat every patient with equity that we're seeing. Because we can see that a number of them, a quarter or so, are dissatisfied with their healthcare provider management. And the one thing that the study came out to show was that while we use both OTC and prescription medications, you could see that the prescription medications generally were regarded with greater satisfaction than the OTC. That makes sense. I still think there's a role for both. Depends a lot on the patient and not just their symptomatology, but perhaps what their insurance coverage is, where they are, and their own preferences and values too. But generally, we know that prescription medications have some good data behind them. In terms of making the positive diagnosis, that's what I talk about with patients. This is something we're going to actively search and make a diagnosis for you. Starts with a history. So with rectal examinations, that's something that we don't do. We do less and less in primary care. And when we're thinking about pelvic floor dysfunction, I don't know if a lot of I think unless we're really assessing that, I'm not sure that we need to do a rectal examination in terms of a digital DRE. What's your take on that? I think if you know what you're doing, that's great. If you train yourself, it's not that hard, but you want to have some straining and you want to feel the relaxation of the anal sphincter. And if we don't really know what we're feeling there, then I'm not sure it's going to really do a lot of good.
I mean, it's good to do a rectal exam, I think, just to make sure there's not a mass, right, in the rectum. So I think for that purpose, it's probably a good idea to do one. But you're totally right. Like, we've done surveys of GI fellows, medical students, and people who do rectal exams all the time, GI faculty. It's a good test if you know what you're doing, right? So obviously the GI faculty who were trained in doing rectal exams for pelvic floor disorders did a much better job, and it correlated with anorectal manometry and physiology testing. So I think for the purpose of mass, probably, it's important to do it as part of your physical exam.
Yeah, as long as you know how to do it, but it's important to do it because if it's very normal. Yeah. When you ask them to bear down, they relax the puborectalis muscle, anal sphincter. It's a really low likelihood they have pelvic floor dysfunction. The issue is if they don't do it correctly, they could still be normal because it's kind of a...
It's a feel.
It's because they're laying on the side, someone has their finger up. It's not exactly how they are on the toilet, but then you should refer them for anorectal manometry because the treatment's different. We do, anorectal biofeedback or pelvic floor physiology, physical therapy.
So what is certainly in everybody's realm is the next point regarding the symptom-based criteria, very straightforward, and I think really built for broadly making the diagnosis. So that's great. Alarm features. We want to assess for those. We exit this protocol when we find one, and I'll go over what those are. You might have extras. So this is a good chance to remind everybody, not only if you have questions, but if you have particular pearls from your practice, please share them. You can put them on the chat, and then we'll go over them at the end. And then you go right to treatment. So these are the criteria. You're probably familiar with the Rome 4 criteria. Rome 5 is due next year, at least 1 day per week for the past 3 months, with 2 of the following: discomfort or pain related to defecation, change in frequency of stool, change in the form of stool. 2 of those 3. I think what I get hung up on a little bit is the last one. I understand there's some chronicity to it that's been present for 3 months and at least 6 months prior to the diagnosis. So if somebody's been having symptoms and they really sound like they light up all of these criteria and it's been for 4 months, I'm going to start the workup that's pretty limited for IBS-C, as you'll see in a second, and think about treatment right from that point. Patients oftentimes have a hard time recalling, but some may come in struggling with this for several years, and they didn't want to, again, maybe because of stigma or embarrassment. Those things are things to be mindful of. In terms of the workup for IBS-C specifically, you don't necessarily need to do special testing when there's no red flags and the symptoms line up and you can make that positive diagnosis. Whereas IBS-M or IBS-D, you want to do, you could do a CRP, fecal calprotectin is what I prefer to do, and you want to test for tissue transglutaminase as well, the IgA. You could consider Giardia or fecal bile acid testing in IBS-D. That's not something I do in my practice, but if they're getting more severe where they need to go on to GI, I think that's something that I defer to their judgment on that more advanced testing. What about alarm features? So, generally a diagnosis among young adults, middle-aged adults. Symptoms past 50 years is something to consider. Undetected weight loss. Please, if you're in gastroenterology and somebody's saying, I have weight loss, I don't know how exactly much I've been losing, but I've been losing weight for over a year, feel free to message me real quick and say, hey, you know the patient. What was their weight, a year ago? Or do you have any previous weights? Because I found in my patients who tell me I have unexplained weight loss, I've got a chart right in front of me and I can look up and I can find that actually they may have gained 3 pounds in the past 2 years as opposed to losing weight. And it's not to take away, I know where they're coming from, but I'm also thinking this is not an occult malignancy. And so we can talk about it and maybe find out a little bit more. That happens at least a third of the time, if not maybe closer to half the time. Blood in the stool that you can't find an obvious cause for, that is another reason to do a rectal exam. I was thinking about that as I said, is that you want to look at the perirectal area as well. Assess for hemorrhoids. Symptoms that awaken during the night, that's unusual. That's a red flag. Any fever. Anybody who doesn't really fit in that category, this is usually more of a slow burn diagnosis. It gets worse with things like stress. So maybe if you were about to be evicted or something and now you notice your symptoms have accelerated a lot, that makes a lot of sense. So I always ask patients if they're experiencing newer symptoms or a change in that pattern, what they think might be going on. And many times, they might say like, well, I'm under so much stress, I started drinking alcohol again or something like that. And then I got a context to work from there, as opposed to thinking that it's another occult malignancy. And then family history is really important too. I would love to hear from my GI colleagues on this. So when my patients present with IBS symptoms, if they have not, so IBS-C, it's not an automatic colonoscopy by any stretch, but if a patient presents to me and like, I've had this for years, I'm now 46 or 45, and symptoms very much correspond to IBS-C, I will probably refer for a colonoscopy, not for the positive diagnosis of IBS-C, but because they're due for colorectal cancer screening and they're symptomatic. It's not which is, I would say they're above an average risk patient at that point if they're having significant constipation and pain. So yeah, I for a lot of my patients, and please don't judge me, I use a lot of stool-based testing for my average risk patients. It's effective, it gets the job done. I think what it does is it saves those higher risk patients for gastroenterology, but not for folks with IBS-C. And then, as was discussed, there are a lot of these functional bowel disorders go together. So, functional dyspepsia, GERD. When you have a hypersensitive gut, I like to tell patients, it's sensitive all the way throughout. And so, and honestly, many of these patients also present with neuropathy or chronic low back pain as well. So there's a lot of symptomatology that can go, into association with the diagnosis of IBS-C. But I certainly regard this on its own and treat it independently as well. So yeah, I guess we could have a little discussion now about some of the points I made, or anything you want to debate, or me to elaborate on further.
Well, I think that exactly what you're saying, that in patients without alarm features, you do colonoscopy or colorectal cancer screening just as the general population. But if someone does have like bloody stools or some other concerning factor, then definitely you can do it earlier. I think the issue is that you don't want to keep repeating it. That's what I see a lot. There's multiple upper endoscopies, colonoscopies, but their symptoms haven't really changed. How do you handle patients with, with a lot of comorbidity, and do you refer them to different individuals? What's your approach?
So I think for our IBS population, they have migraines, they have a lot of times fibromyalgia, I think in the older age range with the IBS patients. And so, those are patients I wish I could refer to a rheumatologist, but many rheumatologists, as you guys probably know, don't want to see fibromyalgia, which is sad. So a lot of times, hopefully they don't end up with pain management that's just going to put them on, like narcotics. I hope that's not the situation. But usually we'll just start them on central neuromodulators and hoping that it will also target the other symptoms. The other one is functional dyspepsia. So a lot of times the IBS patients will have upper GI symptoms as well. And functional dyspepsia, I always call it the sister of IBS. And so, yeah, you just kind of treat it with all of the same central neuromodulators. If you have the luxury of having a GI psychologist, a dietitian, obviously those folks are great to use, and it helps some of the other things as well.
Yeah, I definitely think, and we can get this more in the Q&A, is that it's always good to kill two birds with one stone. If there's treatments, particularly like diet or lifestyle modifications or behavioral therapy or neuromodulators that help multiple symptoms, then really you want to have that as your goal. And you probably manage a lot of coexistent conditions.
Well, nothing makes primary care more excited than treating 2 or hopefully even 3 things with one drug. Yeah. We get inordinately hyped up about that because we're avoiding polypharmacy and hopefully we're providing good efficacy. Tricyclic antidepressants are a good example. They really are a first-line treatment for fibromyalgia. Yeah. The problem I have is I'm always worried with concomitant IBS-C is, am I actually exacerbating? Because what's one of the first things you do with constipation is you look on that med list and eliminate drugs that might be promoting it. But yeah, that said, low dose, you get accustomed to symptoms. Generally, it can be a valuable tool, but it's not for everybody either.
Well, let's see what our score is after our first round. Okay, so Colon Commandos 1902, Motility Mayhem 1558. Yeah, it's close after the first round.
I like that there's a gold and a silver. Nobody's really going to go home empty-handed.
Yeah. Okay, now we're going to round 2, which is the treatment toolbox. And we're going to have our next question, and Baha's going to take that one on.
So what differentiates irritable bowel syndrome with constipation from other types of constipation disorders the most? All right, another 15 seconds.
There we go.
All right, so bloating, right? Bloating, that was my noon talk today. And abdominal distension, abdominal pain associated with frequency, interruption of daily activities, and chronic abdominal pain. So chronic abdominal pain is actually low on that list. Great.
Well, I mean, there's abdominal pain too. So I mean,
Yeah.
you add those up, that's 36. Because that's what I would have said would be the pain. Yeah. But the interruption of daily activity is a really good point too, because that's we're talking about significant disability, which we've already covered.
All right, very good. So now we're going to talk about the most bothersome symptoms in patients with IBS-C and abdominal pain based on this survey that was done a year ago of 653 patients with IBS. Then it was straining. But there's other abdominal symptoms that we don't always talk about: bloating, painful bowel movements, incomplete emptying that patients will oftentimes report, and other such symptoms. Right? So this is, again, the same survey that looks at patients typically experience IBS episodes, and 6 out of 10 patients with IBS-C experience, again, bloating, abdominal cramps, fullness, excessive gas, fatigue. So we don't always talk about fatigue, but a lot of our patients will have trouble sleeping and they'll complain of fatigue. Nausea is up there, heartburn, GERD. These all overlap in patients with all functional bowel diseases, but IBS-C included. And you have to be aware that there's more symptoms than just the Rome criteria that we use. Right? Oh, it's nice. Okay. So the impact of IBS-C is on not just physical, right? So there's the physical impact, there's the mental, and then there's the social. The physical impact, based on the survey, 3 out of 4 patients experienced episodes at least weekly. And so this is very often that patients are having symptoms. They report constipation, bloating, abdominal cramps, pain as their typical symptoms in their IBS episodes. For women, menstruation worsens their constipation symptoms, belly pain and bloating. That makes sense, I think, to at least half of us in this room. And then the mental disturbances, 57% reported a diagnosis of anxiety. So these are all comorbid diseases that we see in patients with irritable bowel syndrome. In general, 42% had depression, and 1 in 4 said that IBS-C significantly negatively impacted their mental and emotional health. As far as the social, we all know that these patients, have trouble going out with their friends. If they're having symptoms, for example, right, it affects socialization. That has a huge impact. 46% rate satisfaction with social activities as just fair or poor. And so, again, it affects all their different components of their quality of life. And in this nice study that was done, they looked at IBS patients versus healthy patients in terms of their adulthood life events that were seen as negative events. And the amount of negative events that happened in both of those groups were about the same, but there was a greater negative impact score in the patients who had irritable bowel syndrome. And when you combine the negative and the positive scores and events that had happened, the IBS patients obviously had a much more negative impact, and the patients that were healthy, they were positive, right? So the total impact was positive score. And then we know these are all the childhood experiences that can affect our patients with irritable bowel syndrome and increases risk. So of course, sexual, emotional, physical abuse have their toll. Then there's household dysfunction that has been looked at. So parents being divorced, parents being treating them violently. Household substance abuse is a big one. Mental illness in the household, and then incarceration. And 2/3 of IBS patients that have been surveyed have more than one of these adverse childhood experiences that they report, and it's a twofold increase in the risk of irritable bowel syndrome in these patients. And the higher number of these adverse childhood events, the higher the risk of irritable bowel syndrome. And we also know that there's a higher prevalence of these experiences. So emotional abuse, this is a survey that was done by Lee back actually this year, and they looked at emotional, sexual, physical abuse. Oops, I have the scores here, sorry. And you can see for emotional, sexual abuse, substance abuse in the household, household mental illness, and parents treating violently, all of those were significant as compared to the healthy controls. And then men and women, right? So you can see physical, sexual abuse all in men and women. And this was another survey that was done, and they looked at mental illness and this thing called the false discovery rate. So a rate that's low is a good thing. It means that it's significant and it's a real finding. And what they found was that in the females, household mental illness had an effect on the IBS risk, and also in men. And then sexual abuse was very different in the healthy controls even. So there was a higher rate of healthy controls that had a history of sexual abuse. And then emotional abuse was significant in the women as well with IBS. All right. And then the good news is that this is based on a UK biobank, which is issues, but this survey had 500,000 patients that are in this UK biobank. One of the issues with these surveys is that the ICD code for IBS may sometimes be incorrect, but when they looked at the all-cause cancer, breast, prostate, colon cancer, patients that have irritable bowel syndrome actually have a decreased risk of those things. And that may be because, we were talking about that earlier, it may be because healthcare seeking is more common in the patients with IBS, so they've had other testing as well, and that goes into the cost of care for some of these patients, but there was a decreased risk, but that risk actually increases with age. So that is the good news. And then when we look at treatments taken for symptoms of IBS-C, most of our patients are taking over-the-counter medications, so that's like 46.8% in the survey. Patients that are taking both prescription and over-the-counters is about 15%, and then prescription only is about 13% of patients who are taking that. And again, we know there's a lot of patients that are not satisfied with their treatments, and some of this is contributing to their quality of life and other issues that they're having. So back to Dr. Vega.
Yeah. Oh, you want to keep going?
Yeah. No.
I actually wanted to. Yeah. I was really interested in the adverse childhood experiences and past trauma in general. I just want to know from our audience here, maybe if you could raise hands, how many of you routinely screen folks for past traumatic events, just across your entire patient panel? So few. How many of you screen folks with IBS-C? Because that would. Those who raise their hands, because you're screening everybody. Yeah, I don't screen everybody, but I do know clinicians who do, and it can be very illuminating. It definitely opens up, the playbook when we think about other potential mental health resources that we might suggest for patients, and so I find it's really helpful. Do you have any tools you use for checking for ACEs or past trauma in general?
Yeah, I don't use questionnaires in my practice, but you obviously sometimes it's very hard to ask those questions, I think, at the first appointment. So it's usually patients you've seen multiple times, and they share something, and you can ask, has there anything happened in your childhood that you want to share with us that you think is affecting your symptoms? I think delving too much into it sometimes, you have to be able to handle what you're going to hear, right? So if you don't have a social worker, for example, with domestic violence and other things, right, you could open up a can of worms, and you've got to be able to deal with that. But it's important to find out if they were sexually abused. A lot of times when we send them for anorectal physiology testing, for example, they can have panic attacks in that room. If they haven't revealed it to anyone else, and it's usually the motility nurses that come and tell us. So I think there's, ways that you can ask them, and then you move on, right?
Yeah, I never think it's a great idea to directly ask them. I think
Yeah.
if they open the door saying that this was a difficult time and I had the symptoms, and you can say, if you're comfortable, can you elaborate on it, keeping it open-ended. But one comment I want to do before we move on is, because this is the area I study a lot, is adverse childhood experiences. It increases your risk, an individual's risk for many conditions. It's not just IBS. In fact, it's been studied more in many other conditions, cardiovascular disease, COPD, obesity, diabetes, depression, multiple diseases. It's just that at the time that we're developing our adaptive systems, as the children and adolescents, if it gets disrupted, they're not as resilient.
Well, it's great points. I think it's worthwhile to screen once you have trust, and if you could do so. And if you have to read the room, if you're starting to lead into a question and the patient's kind of shying away and like kind of closing down on you, not the time. You don't want to push that issue. But over time, I find that a lot of patients will open up once they get to know you and trust you a little bit more. And when you do, I think you'll have a richer vein where you can really promote better treatment. So back to y'all. You get to answer this one, so you can mark your answers now. And then we'll get into treatment.
Come on, motility mayhem.
All right, so soluble fiber supplements is number 1, followed by stimulant laxatives, osmotic laxatives, and stool softeners. Stool softeners, interesting. Okay. We'll move forward. So this slide is great. It's just busy and with lots to decode. Recommendations from the AGG and the ACG with a color coding to them, and you can see that there's nuance. The AGA, for example, has 6 different tags associated with it. But I think it's a nice place to start because this is the landscape. It's not just the landscape of possible treatments, it's the landscape for the evidence of those treatments with guidelines that show how much they're recommended. So we can see, and we'll go through all these individually, and I think you can have a copy of these slides, so therefore you don't have to dwell on it too much, but it always starts with lifestyle. So gosh, I don't feel like you can get IBS-C treated effectively if you have an untreated mood disorder, substance use disorder, insomnia, or poor sleep habits. So those are things we really want to watch out for, and making dietary interventions, really working with a patient. What are the foods that might be most offensive for them? If they can identify those, we might remove them and add them back. And then we'll go through the OTC therapies and the FDA therapies in some detail coming up. But yeah, the nice thing is there are options. There's not a one treatment fits all approach. I do find that some treatments tend to be more effective than others, and I'll kind of share that as we go. But at the same time, doesn't mean that your patients might not, eventually need a different treatment moving forward. So psyllium is my OTC treatment of choice. We know that it's effective for global IBS symptoms. Definitely helps in terms of softer bowel movements. The challenge is in bloating and I find that's a pretty common side effect and can be limiting with the application of psyllium, but you want a soluble fiber, not a non-soluble fiber. Osmotic laxatives, you can improve bowel movements, but you're not going to really have much of an effect on pain, which is the real limitation, I think, for most of the therapies we're discussing today. And so therefore, I use polyethylene glycol regularly among folks with chronic idiopathic constipation, but not so much in IBS-C. And stimulant laxatives, again, I use it more for CIC, less so for IBS-C, where I really want to promote the fiber. But for patients who need an extra agent, or if they need a PRN agent for a bad day, I think that either of those are a good choice. This is the only complementary therapy that I routinely recommend in my practice. Of the thousands of different products and compounds out there, it's really peppermint oil that I think stands out. Why? Because it treats the most intractable of the symptoms that my patients have, which is abdominal pain. So I find that it's effective. I find that it's not going to be covered by insurance, so of course I warn patients about that. Also, I'm very clear this is not peppermints that you can buy down at CVS, in the candy aisle. This has to be peppermint oil capsules. But they are available. I think they're very affordable. I don't think they're game changers, but they can help with symptoms, again, in patients who many times I don't have a lot of recourse to really improve their abdominal pain. So I find peppermint oil to be a pretty good adjuvant agent. But probiotics, I don't. Not really sure. So I really use them only for folks at risk, who are on prolonged antibiotic therapy or at risk of, any type of enteric infection. But they don't really have a strong role. The evidence is highly mixed when it comes to application in irritable bowel syndrome, so I'd stay away. But another thing to embrace is cognitive behavioral therapy. Boy, if you're lucky enough to have hypnotherapy available to you, these are well-proven treatment plays. I have a friend who's a psychiatrist. He says if you're ever on an exam and one of the answers is cognitive behavioral therapy, always mark it because it works for everything. It's been proven in some study to work for but particularly for these patients, because of that history of ACEs, because of the contemporaneous mood disorders or other anxiety, depression, etc. I think CBT particularly has a great role, and hypnotherapy has been proven to work as well. And unfortunately, we don't have enough mental health care professionals, right? So sometimes, what I do with my patients in a low-income setting is, okay, who else? I mean, who are your family? Who are your friends? Are you a person of faith? Because that's a free service right there with a lot of folks who will listen. And maybe there's centers or nonprofits around you that might work in these areas. Just trying to build a sense of community. Interestingly, when you look at folks who live in a food desert, who have violent neighborhoods, who have everything stacked against them, but they have a social network and they have a sense of belonging, it improves outcomes amazingly, including for conditions like IBS. So given that shortage of mental health care professionals, what about the use of digital therapy? I see an older patient population, so there is a big digital divide based on what age, culture, language, income. But there is research showing that these products actually do work, so that's nice to see. They are evidence-based. There's Regulora, which is now available in Canada. I think it's led by a moose. But no, that's not true. But it has been shown to be effective, and this is just in a field that's continually evolving. For my patients, they don't want to pay a lot for an app. They want it to be convenient, on demand, ready for them. Simple, basic instructions. So you really want to make sure the language is something that patients can understand. You really want to kind of target like at max like a 6th grade reading level, and it depends and lower if you're in my setting. And so those are things you want to, and it's worthwhile to play with some of them and kind of see what they have to offer, and that might help you differentiate which one you want to recommend. But it's constantly changing. Leisure time physical activity is a big deal. So this is a study looking at 9,000 US adults, looking at their exposure to leisure time physical activity specifically. You can see they use pretty standard definitions. Our goals are to have 150 minutes a week. That's our national goal for leisure time physical activity. And of course, it did correlate with the presence of constipation. So I think that's something we're pretty familiar with and not that unusual. There is something about leisure time physical activity that is healthier than physical activity related to labor. So I have a lot of patients who clean offices or houses for a living. They're in landscaping, they're in construction. It just doesn't seem to move the needle in terms of the health outcomes when you look at mood and sleep and even constipation. The leisure time physical activity, there's something about enjoying the thing you're doing that gives you that extra spark. And the other thing I'd point out is that folks who really go really into exercise, and now they're exercising at intensive levels, 300 minutes a week or more, they actually don't do any better than folks who just do moderate levels of exercise. So you don't really get, it's not a linear association. It kind of, there's a topping out of the effect of physical activity on a lot of different outcomes. Yoga is also proven, and I really like this because it addresses sort of that that mind-body connection that we know is so important in IBS specifically. So I feel like this is a form of meditation and exercise that's directed most specifically at the pathophys of IBS. I've done a few yoga classes with friends, and I can't do them. I start out, I don't know if you've tried, how many of you tried yoga? It starts out with like, I'm really bored, this is why am I here, and then quickly somehow devolves into, I can't do this, ow, 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 and then I run from the room. So it's been a very characteristic pattern, so I'm no longer doing yoga, but I do recommend it for my patients. And the key is start low, go slow. Find somebody who can actually work with you and kind of work at your level, and then build from there. So overall, in terms of initial treatment approaches, first of all, these should all be done in the primary care setting. So and it's something to reemphasize because we start the yoga class or we start using peppermint oil capsules, but then we get busy, we get distracted, and lo and behold, now it's been like 4 months and we don't do it. So we want to return to your ground game, and I think that's what primary care is very good at, is making sure we have that baseline done. And sometimes patients just need to hear it from not just their PCP, but their specialist and their counselor and their trusted friend. The more voices you have, the more team you put around the patient, or maybe it's a dietitian, a social worker, etc., a case manager. The more you put a team around folks, the message just eventually sinks in. Maybe it's the connection with the person, or maybe it's just that they're tired of hearing about it and they want to take action. But that's the moment where you really want to ignite and make sure and give them all the support, all the love in the world because they made that change, and then keep promoting it and promoting more progress from there. All right.
I'm going to move to
Yep.
our next question. Which of the following mechanisms of action for prescription agents that are FDA approved for IBS-C are you most familiar with? So these were the 100 gastroenterologists said. So it's more SSRIs than guanylate cyclase activators, sodium hydrogen exchange inhibitors, prostaglandin E1 analog, tricyclics, and serotonin agents. So we're going to talk more about the mechanism of action of these agents. So this is secretagogues and a term that Darren Brenner coined, a retinagogue, in IBS with constipation. So you can see a schematic here. So this is the epithelial lining, and the linaclotide, plecanatide, that you can see in the green, they act on guanylate cyclase C receptors, and they can increase cyclic GMP, and that releases or secretes chloride through the main chloride channel, CFTR. So chloride goes into the lumen of the gut, sodium follows with water, and then it helps to move a stool through. Lubiprostone works on a different secondary chloride channel, but also increases chloride into the lumen with water to follow. Tenapanor is different mechanism of action. It inhibits sodium hydrogen reuptake. So less sodium and water is reabsorbed, so it really retains the electrolytes and the fluid in the lumen of the gut rather than secreting, and that can help constipation and other symptoms. Now, there's different mechanisms by which I've explained more of how they can help constipation, but how do they really help pain? And there's some association with constipation and abdominal pain, but some of those two symptoms, one's more of a motility symptom, one's more of an abdominal sensory symptom, are not highly correlated. So even if you improve constipation, some patients still will have pain or bloating discomfort. So linaclotide is very interesting, and I suspect plecanatide works the same way. So they really stay in the gut. So they act on the epithelial lining. But what's interesting was, we've been always thinking, gee, it's not really absorbed. How does it help abdominal pain? And this was a really nice study. In the epithelial lining, there's cells that called enteroendocrine cells or enterochromaffin cells. And they found over some years that they actually have some neural properties. They start looking like some function of a nerve. And they can actually synapse to the afferent sensory nerves that then go to the spinal cord and up to the brain that transmit pain and sensory symptoms. And they found in this nice animal study with human models with culturing cells that if you have guanylate cyclase C receptors on these epithelial cells, these enteroendocrine cells, and the linaclotide can block that, so it blocks the afferent firing of these nerves to reduce neuronal excitability and pain. So that is why they think linaclotide works. Now, The tenapanor is different. So tenapanor, interestingly, will help to normalize the increased intestinal permeability that's been linked to abdominal pain. So you've heard that term leaky gut, which a lot of the general population knows, but the real term that we use scientifically is increased intestinal permeability or impaired mucosal barrier function. And tenapanor has been shown in studies to normalize that intestinal barrier and permeability because that mechanism is linked to greater abdominal pain. And so that is one way that it is thought that tenapanor can reduce abdominal pain. There's also some evidence that in part it can also block the TRPV1 receptor. This is a receptor on neurons that transmit painful signals. It's not a direct inhibition, but it's more indirect, but there is evidence that that's maybe another mechanism by which tenapanor reduces abdominal pain. I'm going to move to neuromodulators. These are 4 main classes of neuromodulators that we've been talking about. So first we have the tricyclic antidepressants, which is called TCAs, SSRIs, SNRI, and tetracyclic antidepressants. We try to use the term neuromodulators because in GI disease we're not, it may be helpful to treat the coexistent mood disorder, but often they don't even have that, and we're just trying to treat the abdominal symptoms. So we call them neuromodulators. So tricyclics are very helpful. You can use them as first line for abdominal pain. SSRIs have not been shown to be that effective for abdominal pain, so they're more, except for functional chest pain, but otherwise you can use them if they have coexistent symptom-related anxiety or general anxiety, depression. You feel like that's amplifying the symptoms, then SSRI could be helpful. SNRI, which is serotonin norepinephrine reuptake inhibitor, is helpful for abdominal pain, and this is FDA approved for fibromyalgia, neuropathic pain, depression. So this can be helpful if you can't use a tricyclic. And tetracyclic antidepressants like mirtazapine have been shown to be efficacious with upper gut and lower gut GI disorders, and it could also help anxiety, depression, and poor sleep. So I'm going to take you through each one. Now, tricyclics work on multiple receptors. That's the beauty of it, but it also has side effects. So it is a serotonergic noradrenergic reuptake inhibitor. It is an SNRI. It just has other qualities. But the SNRI quality is going to help mood and help pain. It also is an anticholinergic agent, so it's going to slow down motility, and that's why it could be constipating. So it's not so great for IBS with constipation, so you can use a tricyclic that has less anticholinergic effect, but one that has more anticholinergic effect, like amitriptyline, would be good if they have diarrhea. It also has an antihistamine effect, and antihistamine can be sedating, which is helpful because a lot of these patients have poor sleep, and poor sleep has been shown to worsen abdominal symptoms or bowel symptoms the next day. So that's why that can be helpful in the right patient. SSRIs only purely work on the serotonin receptor, so it's really going to have more mood. Paroxetine is the only SSRI that has a little bit of anticholinergic effect. The rest of them are going to probably have a more of a pro-motility effect, and paroxetine less so. SNRI is a pure SNRI, so it doesn't have all the other receptor activity like the tricyclics, so that strictly helps pain and mood. It can reduce motility a little bit, so it's mildly constipating, but not as much as a tricyclic agent. And tetracyclic hits many different targets, but in different ways. It's not a serotonin norepinephrine reuptake inhibitor, but it acts on those receptors in a different manner. But it also has noradrenergic or alpha-adrenergic effects, so it slows GI transit as well, has an antihistamine effect, and it works on different serotonin receptors. What's interesting about mirtazapine is that it has a small amount of the 5-HT3 antagonist, which like ondansetron has. So that's why some people also use it for upper gut symptoms when they have nausea. Okay, so that was a whirlwind tour through the neuromodulators. And if you have any questions, please ask them. Let's just take and see where we are right now. So colon commandos are at 3,760 and motility mayhem close. Right after 3157. So we still have some questions to go. So we are going to move into round 3, optimizing outcomes. So Baha's going to take our next question.
Very good. All right. So motility mayhem, you have a chance still. Well, now we're going to go into all the clinical trials and the prescription medication. So This is a nice study that looked at all of the different treatments we have in patients with IBS-C and how they fare for treatment of both improvement in bowel symptoms and then also improvement in abdominal symptoms. And they compared over-the-counter agents, all the studies that were done, and the therapeutic classes of the prescription medications, retainagogues and secretagogues. And so, the over-the-counter agents, most of them improve bowel frequency. I think no one questions that. Stool softeners, maybe not. But the improvement in the abdominal symptoms is really only seen with soluble fiber. So not all fiber, but soluble fiber. But with the therapeutic drugs, we get improvement in both the bowel symptoms of irritable bowel syndrome and then also the abdominal symptoms. The abdominal symptoms being, again, pain, discomfort, and bloating. So we'll go through some of those studies. And now we know that there's, all these different FDA-approved therapies for IBS-C that improve pain. Lynn talked about all of their mechanisms. They're just listed here, including how long they've been available. I mean, before lubiprostone, we had tegasterod, which is no longer available, but that's like when I was in fellowship, that's really the only drug that we had available. And now we have all these other agents, which is kind of nice. So these are all of the different trials and what they looked at. These are all the secretagogues for IBS-C. And it's important to realize that the studies for lubiprostone, when those clinical trials were held, they were held by different FDA endpoints that were used at that time than linaclotide and plecanatide. And so they defined what a monthly responder was as more than 2 out of the 3 months, they had to have a moderate response in 4 out of the 4 weeks, or significant response in 2 out of the 4 weeks. So that was the lubiprostone studies, and obviously it was better than placebo. With linaclotide and plecanatide, they had to have, in their clinical trials, 6 out of the 12 weeks, they had to have an increase in the complete spontaneous bowel movement by at least 1 or more, and then they had to have an improvement in abdominal pain scores by 30%. So 30% in the worst abdominal pain weekly for that 6 out of the 12 weeks. So these linaclotide and plecanatide were also found to be statistically significant in terms of improvement over placebo. And overall, there's very similar responses, despite some of the endpoints are different. And the global IBS patients, which are the global IBS symptoms, which is the abdominal pain symptoms, and then also the bowel frequency, all improved with all of these agents. And now we're looking specifically at these abdominal symptoms. So we gave it this abdominal score, which looks at bloating, discomfort, and pain. Which bloating, again, remember on the burden of symptoms, we said that was like one of the symptoms that's reported the highest for most of the patients that have IBS. And when you look at the abdominal score, there is an improvement with linaclotide over placebo that's persistent, and that improvement is seen in bloating, in discomfort and pain, and it happens pretty early on. At about 2 weeks, you start seeing a separation between the placebo group and then the patients that received linaclotide. And you'll see the same theme for each of these secretagogues. With plecanatide, this is looking at bloating severity. So they actually looked at patients in their phase 3 studies that had moderate to severe bloating scores over 5. And here we see the stratification, and there was improvement in the bloating severity, also abdominal pain severity, and then the complete spontaneous bowel movements per week, all improved with plecanatide. Tenapanor. So tenapanor also, this is looking at the global response with tenapanor. Overall responders is defined similar to what the linaclotide and plecanatide treatments were, clinical trials did. And it is also effective for the global symptoms of IBS and the abdominal symptoms. And we'll look at those trials. So again, this is a pooled population post hoc analysis that looked at change from baseline over the first 12 weeks of treatment. And you can see that the abdominal score, which again calculates the abdominal pain, the discomfort, the bloating, and the abdominal cramping, which many of our patients complain about, all got better and were statistically significant versus placebo. So I think this is all important. And the reason we're looking at all this is because, we do differentiate abdominal pain from abdominal discomfort, and patients will do that, right? There's two different facets of pain. And then bloating is a huge consideration, but it's not necessarily part of the Rome 4 criteria for IBS, but it is a symptom that's commonly reported. And so it's really nice for us to be able to tell patients that even their abdominal bloating symptoms, the cramping, the discomfort that they're feeling, they're going to get better as well, right? They may take longer than the bowel frequency and the stool frequency, but that these drugs also target that, and that's what Lynn was describing, in the mechanisms that she was telling us about, right? So I think that's something, I don't know how you guys explain it to patients, but I think sometimes patients don't realize they're concentrating on the bowel frequency, not so much the pain, that they may get better with the laxative, right? Because if you just call it a laxative, they're just thinking bowel frequency is going to get better.
Yeah, I think the point here is that the constipation symptoms can get better in a couple of days or with a few days a week, but that the bloating, abdominal pain, and discomfort can take, even though it could start in the first week, it could take more like 3 to 4 weeks. So the patient really has to stay on the medication and not expect like in 2 days my pain's going to be gone, and be patient, because to reduce pain, it's a more complex process.
Yeah, I would just say you're absolutely right. The first visit, they're very concerned about their bowel frequency and form, but then you see them. Like telehealth is a good thing to do. Like 4 or 5 weeks later, that's about how my practice works out. But then they're concerned with the cramping and pain. Yep.
Exactly. So that's a good way to try to
And they blame
address
the
compliance.
medicine for it.
Yep.
Yeah,
And
so
adherence to
sometimes, yeah.
medications. Yeah. Perfect. All right. And then, of course, with all of these drugs, diarrhea, we'll talk about side effects, but diarrhea is probably the most common side effect with most of these drugs, obviously, because they are the laxatives and they do increase bowel frequency. And here we looked at the patients and the effects of tenapanor on abdominal symptoms, irrespective of the bowel response. So in these patients, they looked at the mean change in symptoms in the patients that had not necessarily an improvement in their chronic, SPM. So these patients, pain, discomfort, bloating, all had an improvement, even if their bowel frequency, complete spontaneous bowel movements did not improve. And then the same thing happened with their average weekly abdominal score. That also improved, even if they're not necessarily having more bowel movements. So again, I think telling patients that these things can also improve with compliance, with daily taking their medications, I think is very helpful, especially for those patients with moderate to severe abdominal pain. And then this is a question that actually comes up a lot. This was actually an abstract that was presented at a meeting, and it hasn't been published yet, but tenapanor also works de novo. So it's not like patients have to necessarily have failed secretagogues. So they took patients, it was a small amount of patients that had experience previously were taking secretagogues. Most of the patients were secretagogue naives, but there is an improvement even if patients have had an experience. Now, the experience doesn't necessarily mean that they've had to fail a secretagogue, but this agent works by a different mechanism and is still effective in these patients that have taken secretagogues in the past. So there is a clinical meaningful response in these patients that is seen, even if they've taken other prescription IBS-C medications. So these are meta-analyses that have looked at all of the different prescription drugs that we have. You'll see that tegaserod is here listed on this meta-analysis. And they looked at network meta-analysis, looking at these drugs versus placebo, and all of these agents do better than placebo. This is a non-inferiority trial, so you can't compare these drugs against each other. But again, we have all these agents that have helped patients with IBS-C symptoms. And then you see bloating is on the right side of this graph. This is, again, a meta-analysis that looks at all the IBS-C medications, and it does help bloating. Lubiprostone, linaclotide, tegaserod, and tenapanor all help abdominal bloating. Linaclotide does better than the others, but again, this is a non-inferiority trial, so none are better than worse. Now, in summary, we have a lot of agents, right? We have secretagogues, we have retainagogues, and all of these have helped all of the symptoms of IBS, so the abdominal bloating, the cramping, the pain, and then also the stool frequency. And it's, again, these are effective drugs that we have for patients when we compare them with the over-the-counter agents, not all the over-the-counter agents help these abdominal symptoms, which are the pain and bloating.
I think I got it. So try answering this question. Which safety consideration do you contemplate most often when prescribing a treatment for IBS-C? Is it common adverse events, bloating, gas, abdominal cramping, diarrhea, electrolyte disruption, hydration concerns, age of the patient, or patient's morbidities? Those look like the choices on the board.
Thank you. Let's see what the answers are. Okay, so the most common was common adverse events, bloating, gas, abdominal cramping, and diarrhea. So that makes sense. Electrolyte disruption, hydration concerns, those two got it right. Age of patient, and then patient's comorbidities. All right. So these are all the different, adverse events that are reported in these clinical trials. Now, again, all these clinical trials did not report their SAEs and their adverse events exactly the same, but diarrhea is the most common with linaclotide that's been reported as an adverse event, 16% versus 2.3%, and 3.4% discontinued the drug versus placebo, and then there's no SAEs reported due to this diarrhea, and no deaths were reported in any of the trials. With lubiprostone, again, the side effect is diarrhea. Also, another side effect is nausea, which is dose dependent. So that's one of the side effects that may be different with lubiprostone than it is with the others. And importantly, lubiprostone should be taken with food. So that's, again, also different than maybe the other drugs. Pilcanatide, diarrhea is also reported most often, 4.3% versus 1%. And incidence of SAEs was 0.8%. No deaths and no SAEs, severe SAEs due to diarrhea. And then with tenapanor, same thing, diarrhea is reported most commonly, 15%, about 15% versus 2.3%. 11 patients receiving tenapanor had SAEs. So again, this is reported differently than the other trials. 7 patients had SAEs in the placebo group, no deaths. And this is important, so a lot of times we get asked on what do we treat pregnant patients with IBA, who have constipation and IBS-C, right? So, most of these drugs have not been studied. So linaclotide, plecanatide, tenapanor have not been studied in pregnant women. PEG is safe, right? So this is an area where lactulose, PEG are safe. Bizicodyl is safe. And the other agent, even though we know that bizicodyl doesn't necessarily help the abdominal pain symptoms, and neither does PEG, but they will help the bowel frequency. These others, again, we don't know. Prucalopride and lubiprostone are contraindicated, and there is some animal data suggesting some potential risks and cross of the placenta. So now we come to the shared decision making for individuals, right? So there's disadvantages are that there are this distrust, right? There's this power imbalance that occurs. Patients may not trust the healthcare system. There's this implicit bias that we talked about earlier. So these are all things that can kind of be challenging when you're taking care of these patients. It may be the clinician's challenge, right? So a lot of the GI fellows that come through my clinic, it's a clinic, I think they'd rather take PTO during. A lot of times because they feel like, oh my God, I'm going to sit there for 40 minutes talking to these patients. So I think these biases that you have when you go into the room can affect that patient-physician relationship, obviously. And it inhibits you acquiring information that will be very helpful in taking care of these patients. And the patients may feel that the information you're obtaining is not necessarily important, right, at times. So I think educating the patients as well, the information you're retrieving, you're trying to take care of the global symptoms that the patient's experiencing. And then patients may not be able to communicate. Sometimes there's cultural differences. There may be low health literacy. All of these have a huge effect on your treatment pattern. And then educational materials. The educational materials need to be in a way that the patient will understand. So they may not be culturally sensitive, for example. Those are all really important. They may not be in their language. So having different languages of information is really helpful. We try to at least have Spanish language in our clinics, if nothing else. So what can we do? right? So there are tools for screening non-medical factors that influence patient health. I've actually not used these tools, but these are the ones that are available. I don't know if you guys have used any of these tools that are listed here. I feel like I should, but I don't.
Yeah, it's like that with a lot of scales. I mean,
Okay.
we're constantly told to use. I mean, it's great. Yeah. I mean, validated scales makes a lot of sense. I've seen these used. I know their importance. It is really tough in 15 to 20-minute visits to fit some of this in.
And then, low-income families, right? You want to use language interpretation services for those that are not English proficient, social work services. There are some free clinics. A lot of times, those patients can get prescription drugs much easily than others. Guard against the potential bias to influence their medical care. So you want to challenge stereotypes, and then advocate for the elderly, the women, racial minorities, so you can represent them in clinical trials. That's something for us as researchers. So I think this is like one of the last slides. Really, what we've been talking about is to have a successful office visit. You want to listen. You want to reassure the patient. You want to be able to educate and treat. And so we've talked about educating patients about the pathophysiology of the disorder, and making them understand that this is common, that their mortality is not, affected, luckily, that there's no increased cancer risk. You can manage the symptoms with these prescription drugs, FDA-approved therapies, and their global symptoms, which includes abdominal pain, cramping, as well as bloating. And you want to, if you have a multidisciplinary care approach, I think that probably works best, working with a primary care physician. Nurses are vital. They're the ones getting our prior authorizations at the end of the day. Dietitians, if you have the luxury of having behavioral health services available, that's fantastic. And then, of course, us. All right, thanks.
I thought we could just spend a few minutes just talking about some different aspects. One thing that, because I had to look up all the data on pregnancy for constipation, and there's a recent, well, not so recent, it's 2022, Brigstock et al., a Red Journal article that reviewed all the medications for constipation. And it did say for lubiprostone that when they looked at the animal data, that they found that the fetal loss was due to loss in weight and not so much the drug itself, and that there was a handful of women that had perfect pregnancies or healthy pregnancies. And so now all these drugs you could use if the benefit outweighs the risk.
Risks, exactly.
But otherwise there's
grades.
other medications or over-the-counter remedies to use.
Okay, good.
Yeah, so that's something that it still makes me uncomfortable, constipation and pregnancy, but that's something that I learned recently. Is there, do you have any comments about?
No, I thought that was a really good summary. So, I guess one thing is that I don't see that, the rates, I understand it's from clinical trials, but the rates of loose stool associated with synaptol and linactide are definitely higher than I see in my practice. I don't see a lot of patients stopping them, and nor do, when I ask them, they say they're passing softer stools, but I wonder if maybe it's just an interpretation of what the patient, because what the patient thinks is a normal stool and or diarrhea can be widely variable from person to person. But yeah, I just haven't seen nearly those types of rates. I have seen it, but not at where it's going to be affecting 1 in 6 patients. That's not.
I think sometimes what I've seen is that some of the patients have overflow diarrhea, so they're severely constipated, and then you start these drugs, and all of a sudden it's like floodgates open, and then they have diarrhea. So sometimes I'll tell them to take Docalax or something else the day before they start, and so that way they're kind of cleaned out before they start these drugs. So I think with that I have less maybe of the explosive diarrhea.
I have to say it is hard to tell when someone can have loose stools and they have constipation. That I'm not one of these people that get an abdominal X-ray, because you were kind of commenting on abdominal X-ray. In the overflow type patients, sometimes I feel like an abdominal X-ray is helpful to see if there's a lot of stool. And I think that can be helpful.
It also goes back to the digital rectal exam again. So,
Okay, I want to just see what the score is after these rounds, winners. Okay, so it's still kind of, it's about the same. Colon Commando still in first place, 5,092, and Motility Mayhem, 4,573, but both really great scores. I mean, very close.
So,
all right.
So
I didn't have the question.
great job, Commandos. I will say that Motility Mayhem, I think you might have a valid protest.
Yes.
If you want to go to FIFA or the International Olympic Committee or wherever, I think there could be, you probably would get a hearing.
We have time for Q&A. We do already have some questions. There have been some questions about diet. What would we recommend for diet with IBS with constipation?
I mean, I think there's good data with the low FODMAP diet. You know, it's hard to do for a lot of the patients, but I think most of us are now doing kind of a modified version of the diet where you don't have to necessarily eliminate everything. You can start with one and then kind of go through, you know, lactose, fructans. Fructans tend to be high in terms of causing symptoms in a lot of our patients. So usually that's something I'll eliminate first with the help of a dietitian, of course. But yeah.
Yeah, I like to go based on patients' preferences. So because they want to be able to stick to it, and if you know FODMAPs is really hard to stick to entirely. So here's the selection of foods. Which of these do you find one that might be? Have you noticed there's promoting the most symptoms? That's easy, or just do you think you can eliminate because they're not really core to your diet, and then go from there.
Yeah. So one question is, why does insoluble fiber supplement make things better than a soluble fiber food than like bran cereal? But it was actually the opposite. The studies are more insoluble fiber than insoluble fiber. I'm not saying insoluble fiber doesn't work, but it's soluble fiber that has been studied. You know, so Baha, one of the questions is, you know, just the way the clinical trials are designed. With a number needed to treat of about 8 to 10, meaning only 10 to 12% of patients benefit over placebo, how do you reconcile that with recommending these therapies to patients?
Well, I think these trials are very rigorous, right? So, you know, you have to show that there's significant improvement in their worst abdominal pain score, and the complete spontaneous bowel movement has to change by more than 1. So I think, you know, just looking at just the number needed to treat, I think for these trials is probably, you know, IBD trials probably have the same, right? And we don't have a biomarker to check. So I think, you know, they're very significant. A 10% change is actually pretty significant in terms of IBS-C trials with a high placebo response in general.
Yeah, I mean, a lot of these trials were developed to lower the placebo response. So
exactly.
More strict.
Right.
But you can definitely see benefit in patients that may not be meeting the FDA endpoint per se. But that's just how they're designed. Someone had a question just to follow up on my comment about lubiprostone, that's similar to prostaglandins that may promote abortion. Yeah, so that was thought that you would have to test women to make sure they were not pregnant before you put them on lubiprostone. But because of the lack of evidence to show that that was linked to that, in 2012 they actually took that recommendation off. You don't have to do that. But do any of you have you tried in-foods IBS blood tests where it tests for IgA-based food intolerances to guide dietary elimination? What is your comments about the strength of that study and the evidence?
I mean, I think that's the first of the trials, and it was actually done more rigorous and very well designed from the Michigan group. And they took 18 foods that in other trials patients had found to cause IBS symptoms, and they eliminated those in the patients on this clinical trial versus the sham. In the sham, those things were not eliminated. And what I liked about that study was that they also looked at non-adherence to the dietary therapy, which they found like, you know, I don't remember exactly, but maybe 30% were not adherent, which we do find in dietary trials, I think. But they did find a significant improvement in their primary endpoint, which was improvement in the abdominal pain. They did not find improvement in the IBS symptom severity score, which is another marker that we look at. But I have used it clinically. Again, my issues using it clinically was that they have to charge the patient, and just the workflow of getting that test in the clinical setting, you know, it was difficult. So I think that's like what is inhibiting us ordering it more often. And the few patients we ordered it in actually found it very beneficial. And they had some foods that were identified. Yeah. But yeah.
The symptom that it helped the most was actually abdominal pain.
Abdominal pain.
In the study.
Exactly.
So there's a couple questions, Chuck, that I wanted to ask you. And it's, do long-term heart medications complicate the diagnosis or management of IBS? And is there any studies? Another question was, do heart medicines, are they linked to IBS symptoms?
No, I mean,
or heart disease?
right. No, I'm not aware of an association there. And I mean, there's any medication that slows, transit time can promote more constipation. I'm trying to think of the big offenders. I mean, calcium channel blockers which we might use for hypertension. But I find that that's a pretty modest effect of a drug. The most commonly used one would be amlodipine. So no, I think that I can safely use those drugs. But really, constipation, not so much IBS-C, but constipation is such a ubiquitous factor when we look at medical therapy. So just because it doesn't have it, on its old, what they used to call the package inserts, drug information, doesn't mean that it's not real. And so we really want to be careful, especially among our patients with other risk factors for constipation.
Should stimulant laxatives be avoided due to their chance of promoting colonic atrophy in the long term?
I think those studies were old and they've been debunked. So I use stimulant laxatives all the time. I think they do improve bowel frequency, especially for some of these patients with severe constipation. So I haven't found that to be the case.
Yeah, in general, we want to use it probably more short-term relief just because they can cause cramping. But yeah, it's thought that that's really old data, that the old studies where they thought that they were degenerating the enteric neurons is that the patients had that pre-existing.
Now, if they have a history of laxative abuse, I think the patients that have laxative abuse and they're abusing stimulant laxatives as part of an eating disorder, that's very different. And those patients would have colonic dysmotility anyway from having the eating disorder in the first place. Okay, so
I think there's something good to have a discussion on. One question is, what drug do you prefer over peppermint oil when abdominal pain is refractory?
Well, I mean, I would go to one of those prescription agents. So if they
You would use for abdominal pain?
I usually would just go to neuromodulators along with one of the IBS-C medications, right? Because in clinical trials, we don't do that. But in real life, I think a lot of us will do both at the same time because it's going to take a while for the neuromodulator to start having an effect on the abdominal pain symptoms.
Yeah, if their pain's not that severe, I usually try one of the prescription agents first because you want to see in the 3 to 4 weeks, are they going to have some abdominal pain relief? Because if you add 2 treatments at the same time, then you're not sure how they're working. So I would layer the neuromodulator on after if they need to have more pain relief. But not to forget about brain-gut behavioral therapies like cognitive behavioral therapy for IBS or gut-directed hypnotherapy. They have been shown to reduce abdominal pain. And a lot of patients don't want to be on medications for a long period of time, so they're also an option as well.
And it depends on, what the patient is telling you, right? So if they have other symptoms like anxiety, there's depression, and they're not necessarily being addressed in their other clinics for whatever reason, I think that's when I'm like, okay, I think we're going to need a central neuromodulator to be added here, SNRI or something else.
So one question that just came up that's related to this conversation, IBS-C for neuromodulators, what do you recommend for long-term use? So what I usually do is sometimes you start lower and then you have to gradually go up to a dose that you need. So a tricyclic, you might start at 10 or 25, but you might have to go to 50. With duloxetine, you start at 30 once a day, and then you have to really double to 60 to get the pain effect. But what I usually do is after someone's been on neuromodulator for at least 6 months, but I usually do 12 months. Yeah. You're just expecting to hopefully having more of a neuroplasticity effect and normalizing the nerves. And then you start tapering. If you taper too early, then their symptoms usually come back. How about research on acupuncture?
Yeah, there is. There's definitely data with acupuncture and IBS. I think most of them are small studies. They didn't make it to the recommendations on any of the guidelines, but absolutely, I think using an acupuncturist, massage therapist, sometimes that can be helpful. Especially some of our IBS patients have endometriosis. We didn't really talk about that, but in the patients that have endometriosis, sending them on and getting evaluated is really important.
Yeah, some of the older acupuncture trials showed that it was more of the patient-provider relationship that was the beneficial effect, but there is a recent study that is coming out or came out that it shows benefit of acupuncture and IBS. So Baha, do you ever test for sucrase isomaltase deficiency?
Yeah, I do, in IBS-D. So in the patients that have IBS-D symptoms, and usually pain is not such a, I think, big aspect of sucrase isomaltase deficiency, but I do biopsies. You have to do biopsies when you're doing an upper endoscopy to test for that. But more in the IBS-D, not in the IBS-C, I would say.
There were two pathophysiology questions. One is leaky gut or increased intestinal permeability a real diagnosis, scientific diagnosis? It is, and there are experimental ways to do it in research. There's not a good clinical practice way to detect that, but that is. And another question is IBS-C a brain-gut disorder or a gut-brain disorder? It's really the same thing. It's whether or not you want to call it. It's a bidirectional, like two-way highway. We often say brain-gut, but in the disorders, the gut-brain interactions, the experts wanted the gut before the brain to show the predominance of gut before brain, but you really can use them interchangeably. There's another question that I wanted to, that I was trying to get at here. So they said, why do you do a rectal exam for bleeding if colonoscopy is likely to be done anyways?
Well, I think you covered that really nicely. So yeah, you can detect pelvic floor dysfunction. You could detect a mass, or you could detect fecal impaction. So we kind of covered all those bases today. I'm a believer.
Also, some people, you can do an anoscopy. I mean, they just have hemorrhoids, and they've had a colonoscopy. For how long and how do secretagogues, the indication for how long you put someone on a secretagogue?
I mean, I have them on it as long as it works, right? So, I mean, if there's something else that I've looked for, I did a rectal exam or whatever, I sent them for anorectal manometry because they had refractory symptoms. Usually if they're responding to the medications, I don't send them for anorectal physiology testing.
I mean, there's not really an habituation per se, so.
Right.
Yeah.
So I have to go back because one of the earlier comments is in studies that we presented, and there was, I think, a few of them, that abdominal pain or discomfort were present in only about 50% of features, even though that's a defining feature of IBS. Is recurrent abdominal pain associated with disordered defecation? How do you reconcile the discrepancy? I can't recall if it's more of the most bothersome symptom or, yeah, so
54%
Yes.
was the most bothersome symptoms.
Yeah.
That was in the burden of symptoms.
yeah. And
Yeah.
there was another question, is IBS diagnosis of exclusion, meaning you need to rule out any organic disease process first? I think we were trying to make the point.
Yeah,
Yes.
we led with that. Well, that was a while ago at this point, so I don't blame you. You got caught up in the game. But yeah, definitely. And that's something that I think really has to start in primary care. Because if we're saying like, well, I'm not sure about this diagnosis, but I'll pass it to gastroenterology, how's that patient's attitude going to be when they go in there? So really, again, try to make sure, validate their symptoms, validate the diagnosis, get them treatment, and then kind of, shake the pom-poms a bit and say, yeah, I really think it's going to, one of my favorite things is, I think this is really going to help you. I just don't know how much yet, but that's, we're going to follow you up in 4 weeks to start checking this out. And I think patients really like to hear that confidence.
Well, I think that we got through most of the questions. There might be just a couple that we didn't have time to answer, although our time is up. So I really want to thank you all for participating, and to earn the credit, you have to click on the Earn Credit icon or visit the website that's right here or scan the QR code. So I want to thank everyone for joining us. Thank you, Dr. Moshri, Dr. Vega, and we really appreciate all of you attending, and I hope you learned something and it was valuable.